Доброе утро. Одно объявление. Завтра в 9, в субботу в 9 завтра здесь лекция следующая, поэтому вы все приглашены. И сегодня тема «Овальные окна». Профессор Эустахио Онорато, знаменитый итальянский кардиохирург. Он один из изобретателей устройств, про которые будет рассказывать. Все, прошу любить и жаловать.
Good morning, everybody. So the topic of today will be different from yesterday. Can I? So you see upstairs there, this is a beautiful island in Italy. And the place is named Cefalù in the Mediterranean Sea, not so far from Palermo, that is the capital of the region, Sicilia. Very beautiful place. So we were there some months ago discussing about patent foramen ovale and cryptogenic stroke. I do think that nowadays there are more clear ideas on what is the relationship between the patent foramen ovale and cryptogenic stroke, means stroke of unknown cause. So here we are. I'm coming from, my center is in Milano, is Centro Cardiologico Monzino. This is a new university hospital of Milano. And I work very in close relationship with Occlutech, that is one of the companies that made many, many devices. So the topic is, has been very debated in the last 20 years because there are general cardiologists, there are neurologists. Neurologists are more conservative than interventional cardiologists, for sure. And the debate is, does PFO closure give any answer to the question? I mean, it's better to take the patients on medical therapy for their long life, or it's better to do something? When to do something for them? Cryptogenic stroke is something that you had to exclude. So cryptogenic means that no known causes, but in this scenario, there are potential etiologies for the stroke. That is an ischemic stroke. So patient could be on atrial fibrillation, and this is one of the causes for ischemic stroke. Patient could be atheromasic, and so dyslipidemic, and so have aortic arch atheroma. There could be patient with some thrombophilic disorders, means that they are prone to form thrombus on the circulation. And finally, there is also PFO. So cryptogenic stroke belongs to, the causes are fundamentally three. Among the three causes, probably PFO is one of the most important because get undiagnosed many, many, many times. Could I have the screen? Okay, 1.5 million strokes per year in the US, 800 strokes in Europe, in the US. 40% of those are stroke that are due to PFO. And so if you think that the incidence of patent foramen ovale in the general population is 27 to 30%, there is a huge number of people with the PFO that are actually normally with normal life and normal life expectancy carrying the PFO. For 345,000 patients between 18 and 60 years present with a PFO, and the embolic stroke is the cause of this. Costs for these are really huge because they are, generally speaking, young patients. So the life expectancy and the cost for let's say, loss of productivity is very high. So $94 billion spent, at least in the US and in Europe alone, to this problem. So it's a very crucial healthcare system problem. The third leading cause of death is stroke. And you can see here. But I would like to focus your ideas more clearly in your country. And this is the stroke statistic in Russian Federation. All stroke is around 500,000 per year, and 85% are ischemic. We don't care about the hemorrhagic because this is another etiology. But of those, if you can see here that the cryptogenic part of this stroke is 34%. So it means that 165,000 patients have had stroke due to the PFO. And so this is really quite a huge number, because Russia is 170 million people, okay? And probably 170 million, the third part is a huge amount of people. But among them, there is a huge amount of patients that get undiagnosed, and they got the ischemic stroke, and nobody think about the possibility that a PFO could cause this. So this is a crucial problem. Once again, this is the annual ischemic stroke globally, is 11 million. And of those, the patients that have had ischemic stroke and PFO is 300,045. It's not a negligible problem. So why PFO causes a stroke? Because there is a right to left shunt, and with the blood, clots can come and pass through, or they can be trapped. And this picture is a picture from transesophageal echo that focus that this is a real problem. It's not something that we are inventing. And this is the clot that has been withdrawn by the surgeon in the operating room. So there is a biological plausibility of this concept. It's not simply words, but it's proven. What do you see here? A dramatic picture. You have a long thrombus that is trapped in the tunnel of the PFO, and the two parts of the thrombus are going right and left. But you can imagine if this thrombus suddenly disrupt, could go to the brain or to the heart. So the patient is died. Okay, I will simply like to focus on a little bit in further details the diagnostic and functional part of this anatomy. It's not a pathology. I mean, this is an anatomical variant that has many characteristics. The tunnel of the length of the tunnel, the diameter means the width, the septum thickness, the atrial excursion, aneurysmatic or not, and the rims, the size of the Eustachian valve and Carey network that are right atrial landmarks or pitfalls sometime to the procedure. So this is the PFO you can see. So we are measuring the length of the superimposition of septum primum and septum secundum. Septum primum is fibrous tissue. Septum secundum is the muscular part. This came from the embryology. And you see very clearly the inferior vena cava and the aorta. This is a special projection from the echo that is bicaval view. And you can see also the Eustachian valve. The Eustachian valve is something that is very frequent, is no pathology, nothing at all, but it's something that if you have a prominent Eustachian valve and you have a PFO, you are at risk for paradoxical embolism because Eustachian valve is helping in this. So we divided the PFO, generally speaking, as a nomenclature in type 1. It is very simple. There is a tunnel, no more than this. The tunnel could be associated with the hypermobility of the septum primum, or primum, because this is Latin language, primum, septum primum. And type 3 is the huge excursion of the septum primum, probably without tunnel. So these types of PFO is very important for the interventionalist, that they had to choose a device to close this variant, this anatomy. Okay, from the echo color point of view, I don't know if this is moving. I hope so. No. Okay. So you can see this is the type 1 PFO tunnel, very simple. This is a type 1 tunnel, but the length of the tunnel is a little bit more than 8 millimeters. So type 1 can have a normal length, or the tunnel length could be very, very important. We go from 8 millimeter to 20 millimeter, 25 millimeter. It is obvious that this is a simple anatomy, but for interventionalists, cardiac interventionalists, this is to be considered and taken into serious consideration, because if the tunnel is very long, as my dear friend, Professor Buzaev knows, this could be a problem for our choice, what to do with this patient. We should close, but what is the device, the best device for do this? And you can see here, transesophageal echo, the measurement is around 29 millimeters. This is a critical aspect, critical anatomic technical detail of this tunnel. Once again, by transesophageal echo, you can measure the excursion and anything. And once again, you can measure the tunnel in type 1 PFO. So this is the tunnel. This is septum secundum, septum primum. And you can have also large tunnel, not long, but large. Means that the large tunnel may excursion. So probably the tunnel is no more there, and you have to think about what I should do for this patient, what kind of devices I must use. The tunnel could be, as you clearly know, type 3, associated with huge aneurysm. And those are pictures from specimen. And the large excursion could be associated also with small defect on this septum primum. By definition, a defect on the septum primum is an SD. Could be small, could be large, but is a small SD. So you have two conditions: tunnel, so PFO, patent foramen ovale, plus atrial septal defect. you know that at the end, in this patient, for instance, there is a right to left shunt, and the patient got an ischemic stroke. But if you go further in detail, this is really a rare situation, and you must fix this problem. Should we use a PFO occluder? Should we use another device? You have to cover the two holes in the same time. So these are the challenging situations that we as interventionalists face. Okay, I was telling that Bartolomeo Eustachio came from a family, a very well family, Italian family. His father was a doctor. His brother and sister were doctors. I fully follow all the publication of this genius doctor that was the papal anatomist at that time, 1564. And she was born in 1514 in a region in Italy near Rome, and then he died in 1574. She was under the Pope, and he was the first anatomist of the Pope. This situation allows him to have the possibility to do autopsies, because before this time, nobody was allowed to do this procedure. So under the Pope, he has done a lot of autopsies, and this is the reason why he was so experienced, and he published many tables, anatomical tables, that that time was really a referral for anybody. But unfortunately, these tables didn't disappear for 160 years. And then they discovered afterwards, after Vesalio published his own tables, Eustachio was the first to focus on some problem: the Eustachian tube, the Eustachian valve. He performed many studies on renal morphology, nervous system, tooth, and he was really brilliant. So he was the father of this Eustachian valve, and I'm very close to him, very close, because my name is Eustachio. So I saw in my career thousands of Eustachian valve, and I feel very comfortable with him because he was a great man. The concept is that Eustachian valve in the fetal life get a great support to blood bypassing the right heart, because as you know, the lungs in the fetal is not functioning. So blood comes from the maternal placenta and goes towards the PFO that is already patent. Otherwise, it is not possible to survive, and go to the left side. So it's purely oxygenated blood that comes to the systemic system. And Eustachian valve really help in this. So, because there is a orientation from the inferior to the septum primum. And this is the importance. At life, you can have a minor or large, very prominent Eustachian valve. This is not a pathology. This is something that could be interpreted as risk factor. If you have a PFO and an Eustachian valve, you are more at risk. Okay, so taking interest in this valve, I published this mini review on the large eustachian valve. And the interrogative mark is eustachian valve a passive bystander and you don't care, you shouldn't care of it, or is a serial partner in crime? I do think that the answer to the question is the second one. Is really sometimes eustachian valve does do something in crime. So these are transesophageal echo. You can see the valve. I would like to point, but okay, it's this one, huge and prominent eustachian valve. How many cases like this, Igor, did you see in your practice? Huge eustachian valve associated. What happened? What happened? The next, okay, this one. I'm not controlling. I'm no more controlling the previous one. Okay. Do you have any question? You can interrupt me whenever. You're right. You're perfectly okay. So there are two anatomical risks in this patient: the huge eustachian valve and plus the atrial septal aneurysm. So taking into consideration those PFO variables, they should be assessed for decision making, because these cause the risk for the PFO. From the functional point of view, because it's not anatomic, the diagnostic landmark are not only anatomic but should be also functional, means how much blood is coming from the right to the left, what is the quantity. And this can be performed by echo, surely, with bubble test, contrast, agitated saline is not a user contrast by iodinate contrast, but is saline, agitated saline. And functional assessment, on my mind, is better done with contrast transcranial Doppler, because this is the most sensitive, the less invasive, and easy to perform. And those who are experienced in transcranial Doppler can also have an idea of the cerebral circulation, polygono di Willis circulation. Okay, methodologically is a little bit difficult to assess, but to perform, but you have to know few things. And then if you do a methodological correct examination, this is the first step. No false positive, because agitated saline from the antecubital vein or the femoral vein, if you have the patient in the cath lab, the bubbles are 50 microns, and 50 microns that does not cross the capillary bed. So there is no possibility to have false positive. If there is some positive and delay response, you have to search for other right to left shunt that could be at the extracardiac level. And I mean, I refer to pulmonary, artery pulmonary vein fistulas. And this is extracardiac, but the result is the same. You have a right to left shunt, and you are aware of this by a transcranial Doppler. So I would like to share with you this case. We suspected that there was some extracardiac shunt, and in fact, we inject in the distal portion of the right pulmonary artery, and we saw such a beautiful pulmonary AV malformation that was the cause of ischemic stroke in this young patient. There is another cause of pulmonary AV fistula, and we discover it in this young patient that is clarinet specialist. So he was doing many times a day Valsalva maneuvers. And so we discovered that he got an ischemic stroke, and probably the cause was something from right to left. And there is an important message for transcranial Doppler. Transesophageal is done with the probe in the esophagus. So many patients need to be anesthetized. And when the probe is in the esophagus, Valsalva maneuver cannot be done correctly, as you can imagine. So the transcranial Doppler is more easy to perform because the patient does not practically, it not depends on the position. He can raise up, and you can do the test in standing position. And this is very useful because some right to left shunt are posture dependent. And this is very important. Platypnea, orthodeoxia is one of these causes. Okay. We published an article on stroke about the role of the position when you perform some tests to verify if there is any right to left shunt. And this is very important, particularly in this syndrome that is platypnea orthodeoxia, means that the patient is desaturated when he's laying down, and in standing position he has dyspnea, and he had to lay down. And in other situations like scuba divers and neurosurgical procedures on the posterior fossa, I will explain you later on. So what to do with a patient with a PFO? Let's say a young patient, 20 years old, got an ischemic stroke, and you cannot rely on risk factors because he does not have any hypertension, he's not atheromasic, he's not diabetic, nothing at all. So cardiovascular risk factors are zero. There has been a long debate on this, and since the year 2000, there were many non-randomized case series, and case series is not the law for the scientific community. And then from 2011 to 2016, there were initially some randomized control trial that were suggesting that probably closing the PFO, mechanical closure, is better than medical therapy. But at that time, those randomized control trials were not so, let's say, sophisticated or very detailed. The situation then goes into confusion because there are no guidelines, and doctors were not supported by the clinical based evidence. So there were 3 trials and this is Closure 1, PC trial, and Respect, and they were negative. All those three were negative, not supporting the idea that by mechanical closure, the problem will be solved. So their suggestion is keep the patient on medical therapy. And this is a fake news because it's not like this. We can judge about the methodology of these trials, but let's say that they use the wrong device, the wrong PFO, because you cannot put into a trial a patient with a non-hypercoagulability, because this is the risky patient that should be closed in principle. Then came 3 randomized control trials, very well done, and they have been published, curiously, in the same issue of the New England Journal of Medicine. Close, the French study, reduce the long term of the previous, the long-term Respect, that is the second part of the first Respect, and reduce. You see the p-value, totally different, because they are including the right patient with the right device and the right experience to do. Because if you do 2 cases a year, you're not a referral center for PFO closure, obviously. So this was 14 September 2017, and we have finally, we have the evidence-based medicine that closure is better than medical therapy. 4 positive because the fourth was a defense PFO trial that came from Asia, and once again demonstrated the advantages of percutaneous treatment over medical therapy. So no doubt that nowadays this is an evidence that you shouldn't put in discussion, because closure is really reducing the recurrent events. So in carefully selected patients with PFO and cryptogenic stroke, closure is significantly better than medical therapy because reduce the recurrent event in a new infarct, new brain infarct. In 2018, finally, the Food and Drug Administration accepted Amplatzer PFO, that is an American device, to be at disposal of the patients. So when in Europe, we were using since 1997 Amplatzer PFO occluder, in America and US, they finally have the freedom to use the dedicated PFO occluder after a long trip. So this is really, for me, not understandable. But it's like this. And in the same year, few months later, FDA approved the second American device, that is Gore. I mean, in the randomized control trials, you were free to use Amplatzer PFO, but not in the general population. This is the, and nowadays it's totally open for any kind of patients. In Europe, these make a difference on the reimbursement. And nowadays, in a country like France, in France, there are spectacular neurologists. The French neurology is one of the biggest part in the history of medicine. And they are very speculative. And for years, they were a little bit stopping the proposal to go those PFO, those high risk and guilty PFO to be closed. And in 2015, I'm in contact with France and many countries in Europe. my colleagues told me, you know, a neurologist practically stopped our claim for PFO closure. And in fact, in 2017, before the closed trial was published, in France, 60 million person, only platypnea orthodoxia was the indication for a PFO closure. So you can imagine how many thousands of patients that need to be closed still have anticoagulants or antiaggregants without any proven benefit. Since the clause was published, and the principal investigator is such an important French neurologist that is Jean-Louis Mas, they started, but very, very quickly. And in the first year, they were closing 5,000 PFO. It's incredible. Okay, so let's go on. We didn't have guidelines until 2017. In Italy, we were more than speculative, and we wanted with our scientific societies to try to have some position document on what to do, in what kind of patients you should consider PFO closure or not. So if you see this algorithm, is exactly what we published in 2013, much before the US guidelines. And simply, if you have a first stroke in a patient that are no anatomical risk for paradoxical embolies, you should go to medical therapy. On the other hand, if you have a patient that has recurrent stroke on medical therapy, it's quite obvious that you should do something, and you should do a closure. In the middle, there is a gray zone, as you can see in the middle, that you have to discuss with the patient, because the patient may have one or two risk factors from anatomical point of view, and is not responding well to medical treatment, and you should interview him and expose your ideas and take a joint decision. But the most important of this algorithm is that there are anatomical risk factors that are long tunnel, eustachian valve, atrial septal aneurysm. On the other end, you have clinical risk factors. It's different when, let's say, a scuba diver goes to 3,000 times in a year underwater. He's a risky professional. He's not doing this job as a leisure, but it's his professional life. Or you may have a patient with constipation, and when he goes to bathroom, Valsalva maneuver is so strong. So there are some moments that the right to left shunt could be a risk. Long trip, long immobilization. Those are all clinical conditions that can ameliorate increase the right to left shunt. And so you have to be aware of this. So this has been later on published on Lancet, and these are Italian contribution to this field. Since 2013 to 2019, once again, our scientific societies, together with the other European societies, but the movement came from Italy. We were pushing at the European level to have the same that we have done in Italy in Europe. And so, as you can see, this has been published. I do think that this is one of the most important papers on PFO, because it's the European position paper on the management of patients with PFO, and particularly cryptogenic stroke. The same Italian group of scientists and many others, England, France, whatever. So we have this algorithm always a little bit based on what we demonstrated. You had to consider anatomical risk factor and clinical risk factor. And so the algorithm is very clear. You can go to antiplatelet directly, or you can go to closure directly if there is an high causal link, relationship, and risk of recurrence. You can find those guidelines if you are interested by PDF. I can send you. You have Igor. You can help them. So, patient 1865, generally speaking. I do not agree totally with this limit of age. We confirm cryptogenic stroke or transient ischemic attack or systemic embolism, means coronary artery embolism, because the clot passed through left atrium, left ventricle, aorta, and generally goes up to the cerebral circulation. But we have many patients, not so many, but some patients, the clots, instead of going on the cerebral into the cerebral circulation, goes into the right coronary or the left coronary. You can imagine that if you have acute coronary syndrome with an ST elevation in a female patient, 30 years old, you cannot advocate any risk factor, because the patient does not smoke, no hypertension, no dyslipidemia, no diabetes. So what is the reason why a young lady had an ST, supra-ST elevation suddenly occurred? So we were thinking that probably in this patient, we should search for anybody. Of course, we take care of the coronary arteries. And I can assure you that we extracted a red thrombus in the left main, the left descending artery. So this is curious. And the red thrombus was a red thrombus, means that this thrombus came from the peripheral circulation, the venous circulation. So this clot came through from the right atrium to the left atrium, to the left ventricle, aorta, and was trapped into the coronary arteries. So you can imagine how difficult can be the thinking of on this, but it was really the things to do. We extracted the thrombus and then we decided to close the PFO. And this lady is still alive, doing fine. The second message is that you are not a neurologist. I mean, I'm speaking as cardiologist, as Professor Buzek. We are not neurologists. If you see some CT or NMR brain images, you can argue that, okay, this could be this technique or the other technique. We saw the ventricles, but we cannot state really as cardiologists what is the localization, what is the importance of this lesion. Is this a lesion or something else? So you had to work, in other words, with the neurologist. And our team was then heart and brain team, because by yourself is not a good idea to decide what is the neurological aspect of this ischemic stroke. So you should ask a neurologist, and neurologists should be with you when doing selection of the patients. So why? It's really obvious. Juvenile patients sometimes have dissection of the vessel, supraortic vessel. If you have dissection, you can have the same images at an NMR brain NMR. But the cause is totally different. There is no embolus. This is a dissection. And you should take into consideration this. The first things to do from a neurological point of view is do a supraortic vessel Doppler. And you would need something that is expert in this field. For instance, those lesions on NMR, those are named white matter lesions periventricular. But are those infarcts, really lesions, or something else? We don't know. And if you ask a neurologist, he will tell you probably this is water in the perivascular space, Wirkow-Robin space, or a border zone limit, and this is nothing related to the ischemic stroke. Or you can have deep white matter lesions deep in the parenchyma, and all these, as cardiologists, are not able to differentiate. So you must be very honest, and with a great burden or humility, take into account to have a specialist on this to help you for the benefit of the patient. So this could be lacunar lesions, vasculitic. The differential diagnosis when you have multiple ischemic lesion is demyelinating disorders. And this make a difference, because if you have an ischemic stroke, two little ischemic lesion, vice versa, multiple sclerosis is something else, totally, with a worse prognosis. So you have to be very clear with differentiating. Another thing I've learned in the last 20 years is that migraine aura patient, generally female patient that are suffering from not responsive migraine aura episodes, have those kind of alteration in the brain NMR. And you should be aware of this also. So what is the gold standard for diagnosing a PFO? Should we use transthoracic, transesophageal, or transcranial Doppler? What would be your position? I do think that we had to use what we have. So complementary methods are better than a single one. By definition, in the European position paper, we start with the most simple, that is transcranial Doppler. But you need to have also transthoracic or transesophageal just to verify the anatomy of this PFO. So this is briefly the algorithm when you are in your outpatient clinic and you see a PFO, a patient with a PFO on a previous ischemic stroke, what to do? Transcranial Doppler or contrast transthoracic. Both are contrast. I mean, you have to search for the shunt. It's more simple TCD. Okay, you go for TCD. If it's negative, and this is the most important message, you should stop, because you don't demonstrate any right to left shunt. So there is no reason why going into further details with this patient. if the two contrast examination are positive, you should go to transesophageal because it's unpleasant technology for the patient. They need some sedation or even anesthesia. Just to see what is the anatomy you are facing. And the anatomy could be this: multiple lesions, aneurysm, and so on. So you have to clearly understand what is the situation, the anatomical situation. You see, this is a transesophageal contrast, transesophageal echo in a patient after a Valsalva maneuver on the left. On the right, you see such a massive right to left shunt. You can see massive, huge, in basal condition. What is the difference between the two? The patient on the right has really very high risk because in basal condition, in normal condition, he has continuous massive right to left shunt. Okay, and so you have to put all together: aneurysm, Eustachian valve, right to left shunt, huge, massive in basal condition, and so on. Chiari network. Those are all the pitfalls in the right atrium cavity that could enhance the possibility. So this is PFO related to cryptogenic stroke. The second chapter is even more interesting on my mind. We were questioning about our expert in Europe what to do, for instance, if the patient is migraineur with oral, intractable. I mean, any kind of therapy does not work, and she has a right to left shunt, very important right to left shunt. There is no guidelines, absolutely not. So you are not supported. So we think that there are the same group, as you see, European Society of Cardiology. We publish in our journal, and these are very important messages to the scientific community. There are some situations that is PFO related conditions that they have no clear indication what to do. For instance, patient with migraine, I just told you, decompression sickness, desaturation syndromes, and other complex clinical presentation. So we decided that on one hand, is very clear the relationship with cryptogenic stroke. Young patients, et cetera, they have clinical risk factor, anatomical risk factor, and we close. And we are doing the best for the patient. But what about this? Because some of these patients does not have any brain lesions. So what to do? I will try to help you in this consideration by summarizing our paper, our published paper on, let's say, decompression sickness. Patients that do this by for sport is a question, is a problem. But the persons that are doing officially like a work is another more important problem. And divers are being taken into serious consideration, because if you took 100 scuba divers, professional scuba divers, and you have the opportunity to do a randomly NMR brain scan, you will see that 15, 20 of them has ischemic lesion that are silent ischemic lesion. So what to do with this? We put into very brief messages, what to do and what not to do. And in this case, the compression sickness, mainly they had to follow the schemes of diving, and only if they are not related, the event is not related to respecting those protocols, you can take into consideration to close. Another, practically what to do, PFO screening and the compression divers with no obvious risk factor for other things. After decompression, primarily prevent bubbles with behavioral and technical changes. I mean, you can suggest them to do a recovery from the dives very carefully, following the rules. What not to do in all divers, do a PFO transcranial Doppler or transthoracic echo contrast. Migraine, for instance. Migraine is a huge problem, what to do probably is to treat migraine, first of all, with conventional migraine therapy. That could be many drugs. Neurologists are very aware of this and very expert. They change even drugs. And you should consider PFO closure if you are in a trial that can compare the result of your procedure with the medical therapy. This, generally speaking, I mean, what not to do, consider the PFO closure as a part of routine management. You shouldn't absolutely do this. You should send the patient to a neurologist, better a neurologist that is expert in migraine with aura, and then decide together with him. Even though without such a detailed guidelines, I may admit that with my neurologist, I've been working since 1997 in strong collaboration with the neurologist, a very peculiar and very well-known internationally neurologist. He's Italian. For those patients that are not responsive to medical treatment and are migraineurs with aura, try to see in our series of patients that have been followed very well, if desperate patient that changed 5 types of medication with no result, quality of life 0 or near 0, can benefit from the closure. And I may admit that response is unique. The patient changed totally the quality of their life. Many of them abandoned medical therapy. It's something like a miracle. We don't know what we have done. We surely closed the door and impede the right to left shunt to go up to the brain. Probably there is something in not clot, not simply clot, but something, some neurohumoral active element that could enhance or could increase or could start the trigger as a trigger, the migraine aura effect. Okay. Those are my own recommendations from me and my neurologist. You should treat migraine with aura. Without aura is not so easy. You should treat refractory migraines despite the whole treatment. Families with multiple members with migraine, because there is some inheritance in this. You should treat atypical aura. Atypical aura symptoms is neurosensory, vegetative, something that really resembles TIA attacks. And an important message: the patient you have in your outpatient clinic that underwent bubble test by transcranial or transthoracic echo contrast, many of them told you after 10 minutes, 15 minutes, half an hour, that they got aura, endemic migraine. And so the relationship is just there to be demonstrated. So bubble migraine positive patients are the most clear indication for percutaneous procedure. Platypnea orthodeoxia, obstructive sleep apnea. This is very important. Numbers are really increasing each year. They have episode of desaturation and on therapy, and this could interfere with the general coronary risk factors. And exercise hypoxemia, and there are many other syndromes that could be treated, but you should follow the rules. Okay, neurosurgery in sitting position. The neurosurgeon generally do prefer to treat oncologic lesions and vascular malformation of the posterior fossa in the sitting position, because putting the patient in the sitting position, they have a good access to craniotomy. It's very easy for them, very easy. At least in Italy, the neuro anesthesiologists get used, they are very skilled in transcranial Doppler. And as a matter of the fact, they use all time during neurosurgery transcranial Doppler. I was, in the past, I have my sister that have a malformation that was diagnosed by chance. And so as far as we got an MR brain, they stated that this is a malformation of the posterior fossa, and I was present during the intervention. So I realized that for them it's very easy to, but when you cut the venous to go to the parenchyma, many air can go in. And if you have a patent foramen valley with right to left shunt, many bubbles came across. The neuro anesthesiologist will immediately diagnose this. But sometimes it's very difficult completing the intervention, the neurosurgery, because the lesion could be very complex and the patient could be hemodynamically unstable. So what to do in these cases? I suggest that a very simple, cheap, easy to perform examination is one single transcranial Doppler before a neurosurgery. Come on, it's very simple to do. If there is a huge, massive right to left shunt, you should take care of this, because probably the neurosurgery intervention will be very goes with many complications, because you can also even stop the intervention because too many bubbles are coming to the left. So in our mind, in those centers that are get used to do this procedure, neurosurgical procedure in sitting position, because there are some other alternatives to put the patient lying down and not in sitting position, but for those who are prone to use and are willing to use the sitting position, I do think that it's better to have a transcranial Doppler first, because we demonstrated in 2 patients that the massive shunt should be closed before the neurosurgical procedure. So there is also high-risk clinical condition, pregnant women with PFO, puerperium, and so on. But you had to think about each single patient, and you had to discuss each single patient with your neurologist or your specialist in other things. Last, if you have a patient with pacemakers, that nowadays are big camera, 2 electrodes, and the patient is dyslipidemic, hypertensive, they have some hypercholesterolemia, and is old, some thrombus can be attached to these electrodes. And if you don't do the right diagnosis before, you can end up with a patient with a dual pacemaker that is subject to right to left shunt with thrombus, so paradoxical embolism, due to this problem. And in US, there has been a study randomizing many patients, recollecting many patients, and you can imagine how many are there. So in conclusion, this is the interdisciplinary position paper is useful for physician, but for patient, first of all, and is based on sharing decision-making approach, a shared decision-making approach. And this is to state once again that medicine is not one single event or one single patient. There are multiple variants, and you should take care of this. And this is an approach to this condition that is very rational on one man. So you see, this patient has this kind of right to left shunt, massive shunt. If you see the post-procedure, you have a occluder device in place, correctly placed, and there is no bubble coming across. And I do think that this is the only result you should get for the benefit of the patient, because in these cases, PFO patients, you shouldn't be allowed to leave the patient with any residual shunt, because your purpose is to close the PFO. So you have to do the best to obtain. I don't think in the cath lab immediately after, but in the following days, a complete closure. Otherwise, you did nothing for the patient. And with this, I would like to thank you, and if there is any questions. 10 minutes. Okay.
PFOs, 8 or 4 that day, about 70%. So strongest complications like paradoxical thromboemboli. I mean, heart. I mean,
quality of life.
yeah,
Me.
yeah.
It's unbelievable, but the long time, those problems, not only for the intervention of the problem, because you saw the pictures.
Yeah.
If you have a long time, it's very probable that the drug will be captured. So this is the demonstration that surely if you have a molecular shot very important, many things could pass. But even the locality is a problem. So in other words, massive shot or important shot are quite desired, but lockdown itself satisfied. In the name of the lockdown has certainly possible. We are discussing with actually, there are no specific devices. So you can put the teeth, like teeth, something. One for the setting, one for the setting. In large times, we said that the device are the distance between the teeth is 4 millimeters, no more than this. How to adjust this 4 millimeters? Yes, there is some flexibility. 4 millimeters means that you can go to 6, 5. How to adjust this? Those are the devices you don't have anything else. To learn very long time. It will be a distorted device that is not the original shape. It goes most incomplete. So since many years we are thinking about there is a need for an specific device for each entity. I do see yes. In the past we were thinking, especially with some pioneering device, that without exposing this is a big advantage because you don't need it to give other privilege. One to the left, the other one would stimulate and have a weakness since the trigger is small. So we picked up our ideas that I'm putting receivers in Germany. Then we get the device for long time. It's very complex. But the patient has more complex thought. You don't know exactly. Everybody puts something. Totally rapid. So this is so we have an idea to develop model. In order to have those carefully selected patients, those kind of very particular devices, because the device will have more stressor because the device is not educated and you can have more record. So we can see it's the angle. What do you see?
You have a question?
Let's say that instead of putting the here, just put here pro. Start. What happened? Put the back to pro. Back to back. Later the transition. If the back is information, so by doing this, that value of this is the recovery is immediate. Yes, you should stay the line. Afterwards, at least complication to the food. Boundaries that the pain of the athlete. But especially the story. For at least 3 months. Following 3 months, each is the 6-month of procedure, only one is Is it the only 60 months? Must do it. Okay, but we know what is the result of the procedure. When not see over see Maghreb, that judge and be sure that you grow, because otherwise
So we talk about right left shunt and left right shunt. According to some literatures and some books, we talk about right left shunt. So if it's right left shunt, then it will be early onset of lifetime. The symptoms will be from early onset of lifetime. Right left shunt in some books. So we talk about patent foramen, and we said symptoms appear from 18 to 16 age groups. Yeah. So my question is, if it's right left shunt, then when is discovered at the early onset of life? And when we discover it like late set of life? So what are the factors that lead to prolonged symptomatic, like prolonged symptoms?
Well, I didn't understand exactly.
So we have right to left shunt, right to left direction. In some books, it's written that right to left shunts will operate in early onset of life. Like when the baby born, they will have symptomatic hearings for acute symptoms and something. So we talk about foramen ovale, but then for you say you take age group from 18 to 60 age group, and you say it depends on the diameter of weight and also like strength. So my question is, when do we this final derivation have
You take care of the younger.
Yeah, at early onset, but why does it worsen later onset? Does it because of like hypertension or like any other risk factors that lead to these symptoms?
No, there is no relationship with these factors, generally speaking. The cholesterolemia tension is not exposed to blood pressure. In the newborns, they find infants and search for a right shot you will find. Any question for this? You should take care of the right shot. Not at all. Discovered yesterday in the Asian vaccine. There is no seed. Back to right. Should we treat the patient early without symptoms? No. I was alluding to age 1865. Some years ago was 1855. What consecrated ourselves to those strictly? Don't you see that 16 years old baby who have symptoms of unsophisticated attack in association with why not to improve patient? This is the way I'm thinking and I'm opposed to strict limitation of age. Furthermore, working very deeply with this approach, exactly means remain years old. This neurologist is exactly very conservative, but is coming to me presenting an act 80. 80 means that attention, anything. So how can we detect that the brain lesions are not from aging or something else, and not from blood pressure? He demonstrated it. He took any kind of brain for many years previously, and we accordingly decided to close his day. 8 years old. It's not the representation of the qualification. They are generally speaking very young.
Через 10 минут. Сейчас вот 10:35, 10:45. Еще один вопрос. Завтра лекция не здесь, а в 8 корпусе.
I have no other, I should go forward with my list of presentation. Okay. Because before is. Very good question. Very good question.
Вот, я, получается, сначала стабилизацию получил. И чего я в принципе доступен получается. Может встретиться на собой такой Now, we go this window.
Okay.
When you will want.
Yeah.
You will, when will be ready? Please say.
Okay.
Now, are you ready? Yeah. Okay. Can you put the file in the root? In the root, not to search.
Yeah.
And I will go. You will take it.
Okay.
Yeah. The lectures are very interesting for me personally.
I don't know if for them
Anyway, there are some people who will be the good seeds to beautiful flowers. Some people here will grow with your lecture. Not maybe all of them, but some of them have unique experience.
okay. Let you have this. Because I wasn't prepared today to do this. I will deal about Sistema. It is some topic that could be discussed in 1 hour and a half. So, okay, so let's see.
Алло. Да, да. Завтра 8 вечера. Да, да, да. Можно так, если вы дадите 8 корпус, это будет идеально. Да. Конечно, конечно, да, да, да. Там еще ученый совет 12 во вторник, поэтому мне нужно будет, наверное, обсуждается вопрос, что там будет выступать. Поэтому вероятно, что, конечно, то есть мы, получается, читаем все дни теперь в 8 классе. Так спокойнее, потому что в клинике я вот всегда боюсь, что кто-нибудь оказался какой-нибудь мастер-класс там или конференцию какую-то организовал, а мы об этом не знаем. То есть это же такая достаточно определенная система такая, не очень концентрированная. Вот. Поэтому 8 класс, конечно. Да,
Еще раз на всякий случай скажу. The lecture tomorrow will be at 9 a.m. in the 8th in the university. Okay. So once again, the lecture tomorrow will be not here. It will be in 8th building in the university. В 8-м корпусе лекция завтра.
Shall we start? Shall we start?
This is if you are ready.
Yeah, but all students are there.
Um, I will say it.
Okay.
Okay.
Shall we start? We can start. Okay.
They finishing. The
Oh.
end will come.
Okay. Okay. So we will start. Okay. Once again, I will sit because there are some problems with the AVI file, so I have to. So what about post-myocardial infarction, VSD? It's not a defect, it's a rupture. So correctly, is percutaneous and post-infarction VSD, VS rupture. This is the proper concept, I mean. So this is really a nightmare, even in those days at the moment, because there is really few things to do. Mortality is around 90% for all patients, even if they are surgical treated by experienced hands and high volume centers. The general consensus, what to do in a patient with acute coronary syndrome with a rupture, is that you have to do something for their life. We know 90% mortality. If the surgeon accept to treat this patient, you have to be aware of the results that are very poor. On the other hand, there is any help from interventional cardiology? Probably yes, but I do think that the very precise message here, the take-home message, is that the best result you can have are achieved in patients that are surviving for at least 4 to 6 weeks. Means that this is a natural bias, natural bias. I mean, the patients should survive on their own by having help by inotropes and intensive care and etc. etc. The time we need is because the tissue is necrotic, and this is very important for any kind of procedure you take into consideration, surgical or percutaneous, because there is a need to form a scar on the edges of the rupture. So 3 concepts: very high natural mortality, the clinical course of these patients that are hospitalized, and for instance, they are on intra-aortic balloon pumping, the clinical course is unpredictable. There can be a rapid deterioration, and even with the most efficacious medical therapy that you can give to the patient, And when the patient develop a shock, a cardiogenic shock, the outcome is very, very poor. So good candidates for an alternative method, let's say transcatheter closure, is that they are in hemodynamic stable condition, and they are survivors for more than 3 weeks. Those are the good patient to be treated. And the really good patient, better patient, are those who have the issuance of the patch, the surgical patch that had been applied in the surgical theater, and you have a recurrent VSD. And obviously, less and less the diameter of the rupture, the more you have a chance to treat successfully. This is a multidisciplinary approach, means that you have to search for the hemodynamic condition of the patient. And if these conditions are unstable, you should do something in addition to medical treatment and ventricular support. Okay, I will skip this because the message is exactly what I told you. There are some devices, some occluding devices that could be technically applicable to those patients, and came from the past, but nowadays we have different types of Amplatzer devices that could really do the job. In particular, this is Amplatzer muscular VSD, and you know the diameters of the waist that connects the two discs is for 4 to 18 millimeter, but we have a new brand of this, a new design of this technology, that is the post-MI, that has a longer connecting waist between the two discs that can be from 16, the two discs are equal, 16, 18, 20, etc., 24, until 24. And this is named Amplatzer post-MI VSD occluder. Seems to be a specifically designed device, but I do think that nowadays is over. I mean, the measurement, the waist from 16 to 24 are extremely low for the ruptures. But the most important thing is the distance between the two discs, that is at least 10 millimeters. Okay, how to treat those very complicated and very ill patients? General anesthesia during the procedure, transesophageal echo, better, and some of these patients needs still in the cath lab, if they are shocked, they need inotropic support and intra-aortic balloon pumping. So it is not really the common patient we see every day in the cath lab. It's a very complex and very ill patient. You need to cross the rupture, and you can do it by a retrograde approach, coming from the aorta to the left ventricle and then crossing the rupture. And after that, you should advance a wire to make a loop. And the wire, as you see in the middle of the screen, can be snared either from the jugular, if the location of the rupture is anterior, or from the femoral vein, if the location of the rupture is posterobasal. Those are the rules. I mean, and this is the loop we are forming, because from the right, in no condition you should cross this rupture. It is not possible for us to come from right and go to left. So you have to do this heavy loop in order to help the delivery catheter that will implant the device coming from the venous system, either jugular or femoral. A new approach has been tested, particularly here in Russia, in Ufa, with the help of Professor Oziev from Moscow, and we did perform this procedure, avoiding to have the heavy loop. So there are some ideas that are coming and are welcome. Okay, another way to do this is, if you remember yesterday, the perventricular approach could be another solution. But I do think that this is formally done in newborns, and when you puncture a right ventricle in a post-MI patient, could be very dangerous, and you could not find the proper way to get across. So those are the papers that have been published on post-MI VSD closure with devices. You see by the number of the patient reported that case series, only case series, there is not a huge number of cases, but it's not possible to do a randomized control trials on this and have such a huge number of patients for many reasons. One important reason is that nowadays, even in your country, you have access to the system, and a patient with a acute myocardial infarction could reach the hospital within half an hour, 1 hour. So this changed the situation around the world. This has been one of the most successful procedures have been done in the past. It's around 20 years ago with the biggest device, 24 millimeter Amplatzer post-MI. And the patient was a female patient, 76 years old, anuria, and but the great advantage is that this patient was on her 3rd week after infarct. So we found scar formation, and it was possible to implant this device, this big device. The patient survived the procedure. And a few hours later, from anuric, she was fluently, the urine was recollected, and so she was not no more anuric. So those are the total numbers of these 13 publications in 2004 and 2015. I will not go into details, but most studies are retrospective, and no randomized trials is possible because you don't know what is this is a very confounding situation and very critical patient. You don't have time to think. You have to act immediately sometimes. So as you see, the 30-day mortality is still very high after doing the procedure. So procedural complication, this is a very, let's say, technically demanding procedure because you have to have the experience and you have to be fast. Procedural complication includes death or a cardiac tamponade because you are moving catheters in a ventricle that has a free wall rupture. Arrhythmias that can be really life-threatening, like ventricular fibrillation or tachycardia. And you having said that, you pass from the left, from the right side, from the venous side to the left, you can have avulsion of the tricuspid septal leaflet, and it happens sometimes. Hemolysis through the device, and you see how this post-MI rupture has been done with this heavy loop, but the heavy loop, when reaching the wire and wanting to externalize this wire, is coming across a septal tricuspid leaflet that was damaged. You can see from the pictures of the transesophageal and transthoracic echo. Okay, devices are not made for this purpose. I mean, is something like atrial septal defect devices applied to the ventricular rupture. Ventricular septal defect can be amenable to closure, but in special for post-MI myocardial patient, post-myocardial infarction patients, hemolysis could go because the device is porous and is very difficult to get the endothelialization process. And residual shunt could be really the result of your effort to close this rupture. Sheet kinking is a technical problem. I would like to share this with you. So these are 3 devices on a post-MI, very large post-MI device. The patient posteriorly died. You see 18, 16, and 24. There is a portfolio of all devices, big devices that have been put in order to save the patient life. And you see that it's not well endothelialized. And this occurs because the pressure in the left cavity is very high. So the endothelialization is very delayed. Sheet kinking. This is a case of mine where I came from the femoral vein just to solve a problem of a rupture in the posterior aspect, basal posterior aspect of the ventricular septum in a patient that underwent a valve, a surgical AV valve, aortic valve. And then you see the kinking. So it was really very difficult to push the device out. And this could happen. And this make at risk, high risk, the procedure, the entire procedure and the patient life. So as you know, tissue around the rupture is necrotic. So it's friable. And we cannot assimilate this rupture to a ventricular septal defect that has a circular shape, a more regular shape. This is a necrosis, so it's a rupture. And there is a need, probably an urgent need, to have a device that has a dedicated design and could not interfere with the necrotic tissue. I beg your pardon, this AV file was not possible to present. Anyway, this is an acute rupture in a patient that was in an intensive care unit and then go through the rupture, and we saw the rupture at the time it happened. So by color, you can localize and you can quantify the amount of left to right shunt. Obviously, the left to right shunt put in serious difficulties the right side of the heart, because there is an amount of blood that is coming from the left to the right, and is overloading the right chambers. So with this in mind, because we have only the post-MI and Platzer ventricular septal defect, we were thinking with a bioengineer that something could be done to treat this patient and hopefully save their life. And this new design means that the distance between the two discs are at least 10 millimeters, sometimes more than 10 millimeters, because the rupture is not a hole, it's a tissue that is necrotic and could be serpiginous pathway. So speaking with the bioengineer, I explained him that we probably need something that have no radial strength in the connecting ways between the two discs. And this was our idea, to have something that does not disrupt the necrotic tissue, and you can be ready to do this procedure even in the first week after the rupture. And this is very important because sometimes you wait, and the patient finally died in intensive care, even with the intra-aortic balloon pumping. But if you put something rigid, you can end up with a more rupture, because the device itself cause the rupture. And you can embolize the device even though you implanted correctly. So a more flexible elliptical waist is the idea. And so this company made this device, a newly designed post-myocardial infarction VSD occluder device with a welded ball, like all the devices made from this company. The left disc has no hub, and at least 10 millimeter, but more sizes, more sizes, because ventricular septal rupture can be very, very huge. And so we need something to close. And those are the concept of our intellectual property for getting this device on the market. It's not on the market. You may ask for this device by a prescription letter. If the patient is in the intensive care unit, you see that the rupture is around 20 millimeter or 25, you can choose between the sizes and contact the company that will will surely provide you the best size for the patient. But as you can see here, we came from 16 millimeter to 36. It's much more different from the Amplatzer post-MI. Amplatzer post-MI started from 16 to 24. We have more measurements and more bigger devices. And this is very important. Okay, during the procedure or even pre-procedurally, you can have such a sort of approximation, measuring where is the rupture and how is the diameter in the two ways, in the two axes. And this is the first implant, the very first implant, and this has been done by my colleague, Joseph Betucatil, that is a pediatric cardiologist, but he was involved in this idea to modify the device. And you see how the form is very elongated, because the distance between the right ventricle and the left ventricle were much more than 10 millimeters. And so this is the aspect of the device, very elongated device, but it's flexible. It's absolutely flexible without radial strength. Okay, this lady has been down in Moscow a few years ago, in November, this 18 years old lady, diabetic patient, underwent presented at the emergency department with acute MI. She was the grandmother of one of the interventional cardiologists at the National Research Center in Moscow. I was proctoring some procedures with them in the past, and they asked me what to do. I told them, okay, it's too early. This is a primary procedure, so we had to wait some weeks in order to have a tissue that can be suitable for or amenable to be closed by a prosthesis device. So the presentation was on 4th day. There was a rapid deterioration of the clinical condition with chest pain, and the transthoracic echo show this defect that was located at the anteroapical segment with a significant left to right shunt. So during this waiting period to see what is the best for the patient, surely not acutely, they measure rupture 10 times 11 millimeter. It is good news because it's not so extended. So including more myocardial tissue. The patient was hypotensive on the day 12 and quickly deteriorate once again hemodynamically in cardiogenic stroke. So at that time, the prognosis on day 12 was really a nightmare, was around 80–85% mortality. So they started with inotropic support, intra-aortic balloon pumping, and then she got fever. And so the clinical picture was really very disappointing. But at the end of this month, we keep in contact very frequently, and I decided that probably 1 month after, or a little bit less than 1 month, it was time to do something for this patient, knowing that probably the procedure will end up with death in the cath lab. But we discussed this. We discussed the case with our colleagues in Moscow, and we decided to go. So those are the echo pictures of the patient. I can say that transesophageal echocardiography as guidance was not allowed because the patient don't tolerate this. So we have done a procedure, a very peculiar procedure, trying not to damage it, to be invasive for the patient. But the transthoracic echo demonstrated very well that the measurements that have been done previously are corresponding, 12 millimeter. In the anterior apical aspect, you can see the color, you can see the rupture. So we decided to go on choosing a purpose-specific device that is post-MI from Occlutech. We've been in contact with the company. This place is located in Sweden, and I choose 3 devices. One the same of the rupture, and 2 bigger, just in order to have the possibility, if the tissue will rupture again, to have something to close, because those are really emergent and very technical demanding procedure. So we were lucky, and we choose the 20 millimeter device. You can see the pictures. So what was the venous approach in this case? It's a question that I'm forwarding to you. Let's say that we do the heavy loop, and then we push the long sheet into the left ventricle from the right side. In this case, we go from the jugular vein because the anterior apical position was the best to go from transjugular. It's very rational. So we open the device, as you can see here, transthoracic probe and angio control. There is a pigtail in the left ventricle. And then we open the second part. We do some tests by contrast medium. And we saw that the device was really well placed, luckily, really well placed. And the final angio demonstrated that we got a result. I mean, no teeny shunt was present, but the huge hole was, the hole was closed. This is immediately pre-procedure. You see, in the bottom part, there is a huge shunt going to the right ventricle. I will repeat the angio. I beg your pardon. Can you help me going back, please? Okay. I cannot interact with this, with the heavy file. But I want to show them the basal angio on the left here. Okay, anyway, you see the angio is here. We are injecting the left ventricle and we saw the rupture. This rupture is huge, is left to right shunt, very significant, but there is still tissue. And 3 weeks and a half has passed. So the situation is different. It's not acute. It's some necrotic tissue that can become fibrous tissue. And so on the right, you have the device well anchored. You notice the distance between the two discs is at least 10 millimeters. And this is the reality. So bioengineers should have made something devoted to the patient. Okay. No shunt, no more shunt. And we have been successful. The patient recovered, and the colleague that has this grandmother in the intensive care was very happy, was discharged 12 days after, did well at home, and at the control after 3 weeks, he noticed remarkable improvement in their clinical condition. I know by the colleagues that at 6 months, the patient was asymptomatic, and transthoracic echo demonstrated no residual left to right shunt. So this has been a success, and I'm very happy for the patients. I'm very happy for the colleagues. But the decision was really very critically taken. I mean, we wait for having a tissue that can support the device. It's not always like this because sometimes you don't have time. Okay, so these are the control after the procedure, and you can clearly see that the last image on your right is zoom image showing the inner part connecting the two discs, and there is no color across. So this is the really hallmark of the post-procedure. So this patient has been submitted. Okay, it's okay. I took this opportunity to invite colleagues from National Research Center in Moscow to submit this case to publication. And we have been very lucky that this publication, this paper has been accepted in Canadian Journal of Cardiology for published, and it has been published. Okay. This is a primary. What about recurrent post-infarction rupture following surgery? This is another kind of patient. And I do think that is more easy procedure and easy situation. This male it was 55 years old, NIA class 3 to 4, no major comorbidities. Actually, he didn't smoke, and no habit of alcoholism or alcohol assumption or hypercholesterolemia. So suddenly in May 2018, he presented at the hospital with an inferior ST elevated myocardial infarction with chest pain. And coronary artery was done immediately, and they performed a PCI of the right coronary and the obtuse marginal 1 successfully. 6 days after, they showed that the left ventricular ejection fraction was only 40, and there is a mitral regurgitation, moderate to severe, and they saw a large muscular ventricular septal defect, 28 millimeters. And the location of this rupture was at the inferior septum with a significant right to left shunt. So medical therapy in those cases, I do think that is nonsense. I mean, yes, you should do, but this is not a life-saving therapy. In June 13, it was transferred to a cardiac surgery department. And Peter Uzov and Dr. Petrova phoned me from Bulgaria. This was in Sofia, not in Sofia, in Pleven, that is a city near Sofia. And by the fact that we know each other in a congress, and they were aware that I was treating those kind of patients, and they searched me for help. But the decision was to go immediately to surgery because this patient was really a very ill, complicated patient with, and Peter performed a pericardial patch closure of the VSD, and he put a valve, a mitral, a mechanical valve on the mitral position, and he completed the revascularization with 2 bypass grafts, one on the left descending artery and the other one diagonal branch. What happened afterwards? On the 3rd postoperative day, a residual ventricular septal defect was shown. It was not 2.8, it was 1.3 centimeters, but once again, 13 millimeters is something to be cured. I mean, this is due to the fact that the pericardial patch is very difficult to implant because the surgeon, as in our experience, found the tissue very friable, and the easing of the patch can occur. And this is described at least in 20% of all patients submitted to a surgical correction of a post-MI. So Nia class went up and shortness of breath in July, and the local art team decided to do that a redo surgery will probably carry an high risk mortality and high risk procedure, and they denied and they asked for some help. So 40 days after the stabilization and medical optimization, the patient was referred and we decided to go for a closure. As you can see, the location is posterobasal, and this is a very critical position because you have the atrioventricular valve near in the surrounding. Was a huge shunt. You can see here the image from the color, and we measure around 12, 14 millimeter. You can see in the short axis the two images on the bottom that there is something, and the ventricle has a patch that is the double layer image that you see. So the lesion at the patch is on the upper part, on the inferior posterior part. So you have the left ventricle and the shunt through these lesions. It was 18. So we think that probably we should oversize a little bit the device, and we choose 24, and this is the technical details of the device. Rounded shaped discs with the elliptical shape of the inner part, the connecting waist. The eye was 10 millimeter. We have a left disc of 36 millimeter, and 34 was the right disc. The valve, the mechanical prosthesis well functioning. There is a huge hole, and once again we pass across this patch deficiency and externalized the wire in the femoral, because this was a posterobasal location. Okay. The procedure is complex, but no doubt that this is the only possibility for the patient. Okay, so we put the device, you can see. I forward a little bit the position, trying to keep a deep contact with the waist. You see the last picture at the upper right is a zoom image out to show the distance between the two discs that are very, very flexible. And this is the concept of the device. So at the very end, we close satisfactorily these post-lesions post-surgery. And those are the 3D reconstruction of the echo. This is the pre-procedure, and this was the post-procedure. So from August 2 to August 14, and the patient went home really in very good condition, totally recovered. So this is one other success of this challenging procedure. I would say that I would modify this device. These are some prospective analysis on with the bioengineer, putting something on the left disc that is coated with something that is impermeable. So you should close immediately, instantly, the left to right shunt. But those are technical points. In 2020, in the storm of COVID, we had a patient with a rupture of the anteroapical septum in a place that is named Bassano. Bassano is very near to Padua. Is 150 kilometers from where I'm living. They are good friends, and they asked me for to help this patient, 87. 11 days passed from the index event, and we have this kind of pictures. More or less the same measurement, 11, 12, 13, or 14 times 16. It depends on what is your experience on reconstructing images. I should say that nowadays we had to go to the 3D, 4D reconstruction in order to have all the diameters of the rupture. And again, we go from the jugular, and we do once again the AVI loop from the jugular because it was anterior. And at that point, you know, I am advancing this sheet that is something very, very bulky, not very flexible. And this could be a danger because you can disrupt the myocardium and go into the pericardial space and have a cardiac tamponade that is life-threatening. The patient is dead on the table. And finally, we didn't have post-MI. We only have muscular VSD. This could be a problem because we should use the devoted device, but because COVID, there were difficulties even in moving from one center to another, and the company was not able to give us the proper device. But we were doing by transthoracic echo. You can see the left disc is well positioned. We open the other one, and then we have some angio just to see. Still, there is a shunt passing across. And these are the final pictures. The device is not really 100% well positioned. This is 20, some minutes afterwards, but the device was in place, but still with the residual shunt. So we released the device finally, and the device is in place with the control angio that show that still there is shunt. The position is much better, and it seems a miracle, but unfortunately, in this patient, we have a complication from the procedure itself. And it was the disruption of the leaflet of the tricuspid valve during the maneuver of the guide wire. So unfortunately, this patient died a few days later because of the insufficient regurgitation of the tricuspid valve. It's a pity, but it can occur. So this is really the most difficult procedure in the cath lab. Okay, those are the coronary arteries of this lady who is helping me to disclose what is the main problem of these coronary arteries. Do you have any idea? Do you see the left descending artery? Not well. Okay.
Of the circumflex cover
Okay, you're true. The left descending artery is the most diseased vessel. There is some lesion on the circumflex, on the grove, IV grove, and there is some obtuse marginal, but this is not the problem. And the right coronary has a moderate to severe stenosis distally. The device is in place. Okay, so also the case of the recurrent post-infarction ventricular septal defect that we have done in Bulgaria, in Pleven, has been accepted for publication, and this is the report. So the previous images and the post-procedure images. And this is the Canadian of the patient from Moscow, the anterior, apical anterior myocardial infarction. Okay, so technically there are many other things that you can do, but the most important message for the interventional cardiologist is to be in contact with the bioengineer, because ideas came from the experience, daily experience, and they are not aware of the anatomy sometimes, and they are doing something because somebody previously have designed a device. So this is a good option whenever the patient can be treated. I mean, there is a natural bias on this. You have to wait for some weeks, in my opinion, 2 to 3 weeks at least, and then you can be successful. But cardiac surgeon do not want to operate this patient because they have 90% mortality in their historical background, and they don't want to have these. But because they are difficult patients, really, honestly speaking. So what is the incidence, if you know this data? The incidence of post-MI ventricular rupture in your country. Do you have any idea? Because I do think that you have plenty of interventions for acute MI. And you can treat those patients very early. You know, in Basquiria, in Barkostan Republic, the figure of this post-MI person that came and ruptured the septum, you don't know. Okay. But these numbers are decreasing dramatically in Europe. In Italy, we calculate at 60 million people, myocardial infarction, acute myocardial infarction could cause at least, nowadays there are 250 patients with rupture. It's a very small number. Why? Because they came in less than 2 hours in the cath lab and they do reperfusion immediately. So numbers are really decreasing, hopefully. This is a problem in underdeveloping countries that they don't have immediate access to cath lab. So they don't reperfuse immediately the artery, and this is so probably these 250 in a country like Italy could be 2,500 in other countries where there is no access to these opportunities. So with this, I would like to hear some question from you if you have some question. Questions. So probably I've been so clear, or okay. So the same company that made this helped us to have new ideas, but the prototype I'm deciding for the internal closure will be peculiar if we will be supported by the foundation, because we need funds to do this. Okay, if there is no question, I will take some water. And I do think that we finish for today. Please, when you come back to your practice, try to search for this question. How many patients arrive? Yeah, incidence of post-MI infarction rupture. Exactly. How many acute patients have been treated or are treated actually, and how many of them has rupture of the ventricular septum? The aneurysm of the necrotic tissue. Yeah, this is a complication, mechanical complication. Yeah, but probably it's the same figure that is changing, because you are on the far front. So the same as in Europe and other countries, more and more the patient benefit from interventional procedure as soon as possible. Tell me that you like. Tell me that you like my presentation. Yeah. Thank you to you.
We thank you so much.
Yeah.
Thank you for the virus.
When the person is giving lectures and lectures and lectures, he does not understand if the people standing, sitting are happy or not. So you have to, okay. No, you go to internet. Yes.
Okay, so where?
Eustachio Onorато is like this. You're welcome. You are welcome. You are welcome. Yes, probably, but the BST in the infant, in children, are treated in the past were treated with glucosides, digitalis. Now it's more diuretics, and we are very fast. Not let them stay for such a long period. So if they have symptoms of cardiac failure, you should do something, not medical treatment. You know what I mean? So there are small defects. Okay, we can wait for gaining the body weight to be operated on surgically or transcatheter. And yes, probably those are not the very well good indication for cardiac failure as inhibitors, but you can use any another type of treatment.